Vanakkam and welcome to Inia TV. Communication. In humans, it's speech communication. The primary definition of communication is we have a speaker who sends a message through a medium, which is language, and a listener who hears to what the speaker has to share and then responds based on what he or she comprehended. This communication could be broken at several levels, but today we are going to look from a listener's perspective. If the listener has a hearing problem or a hearing difficulty, communication will break down because he or she cannot comprehend what is said and therefore cannot respond back. How do we fix this problem? In general, hearing aids would be for those whose hearing problem or hearing disability cannot be treated medically or surgically. A patient who has a hearing problem would go to see a medical doctor, that's the usual routine, and the doctor would recommend, based on the test that he would do or she would do, would look into and see if this could be surgically fixed or medically fixed. If these two are not possible, usually it would be a neurological issue, the hearing nerve could be damaged, or the infant could be born hearing impaired. So the otolaryngologist will refer the patient to an audiologist. An audiologist will look into the patient's hearing system and test and diagnose the problem. And based on the diagnosis, he or she will pick the most suitable hearing aid, and that hearing aid will be a boon to these patients. Now, I mentioned audiologists. Audiologists are qualified professionals to dispense hearing aids. This is going to be a topic today. Are these hearing aids really prescribed, dispensed, or sold by audiologists or any other professionals? It is not in the recent past, but historically, we have noticed that unqualified professionals slip their feet into audiologists' shoe and prescribe, or should I say, sell hearing aids for monetary benefits. How can this be stopped? And how can this condition be modified? Let's walk into a panel, and I'm going to ask our panelists to introduce themselves. I'm going to invite Dr. M.N. Nagaraja to introduce himself. Sir, over to you.
Thank you. Thank you very much for giving me the opportunity. This is my 53rd year in the field, including student career. Without it, it is 48 years. I am worked from the school therapist to director, chief executive officer. Thank you.
Great. I'm going to go in this order, the one that's showing in my screen. Mr. Manoharan, could you please introduce yourself?
Hello, I am Manoharan. As Dr. M.N.R. described, I have, including student days, it's about 51 years and 48 years of working experience. And I worked as audiologist and speech and language pathologist in Madras Medical College, Government General Hospital. And I was also director in Murphy Institute of Speech and Hearing. Now I have my own setup.
Great. Let me go to the next person in the order, Mr. Taranveer Kochar.
Yeah, hello everyone. I'm Taranbir. I've done my master's in audiology from Nair Hospital. In total, I have about 28 years of experience in audiology. I worked as the director for Sivantos Hearing Instruments till about 1 year back, which spanned a career of about 25 years with Siemens. And now I'm an independent audiologist. Thank you.
Great. May I invite Dr. Kalyani Manke?
Yeah. Hello, Kalyani Manke. I'm in the field since 1975 and established as a private practitioner for last 35 years. Um, Other than clinic, I have a lot of other social activities, of course, which are connected to hearing world, but sort of I feel myself to call it as a social activist more than a clinical audiologist now. Yeah, thank you.
Great. And let me see who's next on my screen. We have Mr. Sugata Bhattacharjee. Could you please introduce yourself?
Hold on one second. Oh, can you hear me?
Yes.
Okay. My name is Shugoda Bhattacharjee, and I'm a practicing audiologist here in US. I run 8 audiology retail clinics with 17 audiologists and 12 hearing instrument specialists. And I've been working here since in the US after finishing my Doctor of Audiology since 2008. And I've worked in India before. And I'm also very active with the American Academy of Audiology. And I'm not quite as an activist as Dr. Manke, but I feel that the rights of audiologists needs to be protected, and the whole legislation in the US that has happened for the OTC hearing aid I don't think is a pro-audiology approach.
Great. Could I invite Ms. Seema Rupani to introduce herself? You might have, yes. There you go.
Hello, everybody. First of all, I'd love to say that Dr. Nagraj, I'm a student of Dr. Nagraj, and it's such an honor to be here with him and with Nanda Kumar. So I'm an audiologist. I graduated from AYJ, and then I went to the UK to do my master's. I'm originally from Kenya. So after having worked in the UK National Health Service, as well as in private practice in the UK, I came back home as such to Nairobi, where I've been practicing independently for the last 11 years. I'm also a trustee of various charitable organizations internationally, where we've been looking at prevention of disability, the ability to provide affordable hearing care as well. So thank you.
Thank you. And let's see who's next in my list. Dr. Suman Kumar, could you please introduce yourself?
Namaskar. This is Suman Kumar. I have graduated in 1999, and since there I've been working in one of the National Institute, and I was the student of Nagaraj sir during my post-graduation, and I'm associated with the institute, which is under ministry and under the Department of DPWD, and I'm there since more than 2 decades in the field. Thank you.
Thank you very much. This panel is going to discuss about what I just mentioned, hearing aids. Who are the most appropriate professionals to dispense or prescribe, recommend hearing aids, and do we call selling hearing aids appropriate? Now, the first step is to look into what audiologists go through in their academic side. So I'm going to invite Dr. M.N. Nagaraja to talk about what do these student audiologists go through and what makes them qualified to prescribe hearing aids. Over to you, Dr. Nagaraja.
Thank you. Am I audible?
Yes.
Okay.
Yes, Dr. Nagaraj, you are.
Audiologist is a professional adequately trained to deal with hearing impairment, right from impairment to disability, and also to work with habilitation and rehabilitation processes of developing and helping in understanding what the person hears. That is the definition of audiology. If we take this definition, what should be there in the training depends upon level. At the basic level of graduation, I am not including diploma here, purposely because it will come later for the discussion. The Rehabilitation Council of India and ASHA has recognized that the title of audiologist goes with basic degree in the area of speech and hearing. Okay. The basic degree includes preparing the person to know why the hearing handicap happens. Is the hearing handicap happening in a person is same in all others? What is the differences? What portions of ear causes what type of problems? Is it just the ear or beyond? And if it is beyond, how it should be segregated from periphery, and the processes involved in investigation. Investigation meaning testing, assessment, differential diagnosis, and then comes the rehabilitative aspect. In the rehabilitative aspect, to begin with, it was thought as a compensation for lost hearing, which was corrected later through the industry that we need not have to go to the threshold level to correct a person. And if we reach one third, and then the formulas change, and also technology change. Therefore, we have to talk in the course on what is amplification, how does amplification help, is that amplification giving 100% correction in the loss obtained or not, if not, why not, and is amplification only answer? What happens if the loss is to that extent as amplification cannot be given? Then the technology improvements like bypassing the hair cell levels and getting into implantations, maybe at some cases in mid-ear and most cases in cochlear level and even beyond. Other than this, can there be problem in understanding what is heard without the hearing at the level of ear being affected? So this type of curriculum is developed depending upon various level and stages where the students go through. In gist, adequacy of giving knowledge to deal with persons having problem with hearing is dealt. Thank you. Have I covered?
Yes. So that makes it clear that audiologists would be the right professional to prescribe hearing aid after adequate testing. Now, let's take, this is from Indian point of view. Let's talk to Mr. Sugata Bhattacharjee and get to know how audiologists or how are hearing aids dispensed in the United States. Over to you, Mr. Bhattacharjee.
Well, unfortunately, and it is, I say it unfortunately, there is a parallel dispensing module in US. I mean, you have all the students, those who go to 4 years of undergrad, 4 years of Doctor of Audiology, come well prepared, then are doing evidence-based, verification-based hearing aid dispensing. But you also have somebody who just has a high school degree, goes and does a 6 months observation, passes a state mandated test, and dispenses the same hearing aid. The only difference is they don't do quite as much as pediatric. But after all this education, you still compete with somebody who has a high school diploma. And that's the sad part. Now, why I feel that the audiologists are more qualified is because it's not just the art of dispensing, you also have the science of dispensing, which we learn at school. But unfortunately, clinical dispensing is not taught in any academia around the world. I go to a lot of programs in US. I travel in India too. So they come prepared with the theory. They come prepared with a lot of knowledge, but they basically learn some basic hearing aid stuff on the job, and most of the time it is taught to them by the reps of certain manufacturers, and it happens globally. And that is what becomes a roadblock. So in US, you have a parallel mode. You have qualified people who does it. You have somebody with a high school diploma who is certified to do it. And but I feel the audiologists are more qualified to do it, but they come out underprepared to do with hearing aid dispensing skills. That's my take.
I guess Dr. Manke has a point to share.
Yeah, I want to ask Sugata, how many audiologists are in the hearing aid field and how many non-audiology or your parallel system? I guess it's my perception or whatever reading I have been doing is 60-40, means 60 non-audiology group and 40% are audiologists. Am I right? Just please correct me.
So that is about correct. That is a 60-40 split.
So that means the hearing aid industry, which is sort of looking at a USA because it's a larger share, market share, and it is managed by non-audiology people.
It is managed. Yes,
yeah.
yes.
And it's worldwide. It's in European countries, same story. So we have to really look into it, why this has all happened. What is it, right and wrong is another thing, but why we exist in this system. Thank you.
And Nandu, I think I'm just taking 1 second. I think what we have to address is if it should not be in a broader brush, like who is qualified to fit hearing aids. If the question is who is qualified for oral rehabilitation, because we are not just giving a piece of plastic. Yeah. So that's So that is the issue. So when you change the focus from just a product to the entire process. Mm-hmm. Then that is when our value really improves.
That's right. Well said. I'm going to invite Ms. Seema Rupani, who has experience both in the UK and now in Nairobi, Kenya, to tell us about how the process is in both these countries, and we can compare that with what we have in India.
So, yeah. I think, Sujata, coming from where you were talking about, historically, let's admit, as an audiology field, we're a very small population. I think that's one of the issues. Even when I was coming from Kenya and looking for an audiology education, there were not many countries that offered a bachelor's undergraduate level of education, and I'm talking in the 90s. That's not that long ago. When I went to the UK also, I was one of the first batches in my master's degree at UCL. So I think this dichotomy of who is actually giving hearing aids comes about primarily because there is a lack of audiology and a lack of awareness amongst the general population. Particularly, there is a lack of awareness as to even what is an audiologist. So when I was starting to work in the UK National Health Service, they had pretty stringent rules at the time on how you dispense, what your requirements are for giving out hearing aids, your pathways to referral, etc. Additionally, what I think happened is a lot of hearing instrument manufacturers realized that there's no way we're going to be able to fit the millions of people who do need hearing aids. And they started taking salespeople and training them into hearing instrument specialists. The process evolved, of course. There was better standards of practice that were created. A hearing aid council was created so that patients had somewhere to understand what should be the minimum requirement they expect of a service when they go to get a hearing aid. And over time, the UK has evolved so that more and more people are conforming to at least a minimum standard of practice. When I came to Kenya, of course, in Kenya, there's even less audiologists. So there's probably a handful of us. What I've done is when I went into my private practice, I've gone for the very best standard of practice that I can follow from a global perspective. I think the first thing that we do as audiologists, when Nandu's asking about process, is we make a connect with the patient. We try and understand their communication requirements and their oral rehabilitation requirements. Of course, we examine the ear, the otoscopy, we look at the history, we look at their motivational factors for coming to us. We perform pure tone audiograms. I'm just saying these things for any layperson who might be watching this, because the audiologists all know this. Additionally, I do also follow and conduct speech testing, speech and noise testing, checking what kind of impact this hearing loss has on a person's daily life, on their relationships around them. Eventually, even selecting the correct path of treatment, which if it is a hearing aid, choosing the correct hearing aid, I think is quite a skill in itself. Choosing the correct hearing aid, making sure the acoustics of that hearing aid are correct, verifying and programming with real ear measurements, validating what we've done, then therefore, in terms of benefit to the patient, perceived benefit. And then following up, it takes, I think on average, at least 2 to 3 follow-ups before the patient is settled with their hearing aid, or whether they've adapted, whether they're really getting the most out of it. So that's quite a scientific, but quite an art as well, when you do have that ability to understand each person's requirement. Was that what you were expecting, Nandu?
Yes, perfect. Else? Yes, thank you. I do have a screen share here from a friend in Australia, and he is going to describe how this is done back in Australia. Let me play that for you.
Mr. Anand Kumar, whom I fondly call as NK, the panel of judges and the viewers. The hearing and audiology industry in Australia is highly regulated. For hearing services, there is a lot of funding from the Australian government. Businesses who provide services to these government patients need to be registered with an approved professional body. There are 2 of these in Australia. One is Audiology Australia, and the other one is Australian College of Audiology. Audiology Australia provides registration for audiologists only, and ACORD, that is Australian College of Audiology, provides registration for both audiologists and audiometrists. The present minimum requirement with Audiology Australia To be registered as an audiologist is a master's degree in audiology. Overseas trained audiologists have to appear for written exams, which test their theory and apply audiology skills. Registration with these approved professional bodies for audiologists is reviewed on a yearly basis, and one of the most important requirements to keep the registration updated is to meet the requirements of the annual CPD program or the continuing professional development program. Now, mind you, these professional bodies do send information to the Office of Hearing Services, the information about the audiologist registration and if they have been updated or not. In brief, without registration, an audiologist cannot provide audiology services. The bulk of the clients in Australia are government funded. That would be close to 70% of the market. The rest 30% of the market is self-funded or patients who pay for their services privately, but these patients will still go to a clinic who provide services to the government-funded clients. I firmly believe that audiology is a specialized profession and a trained audiologist can provide an individual rehabilitation program for the clients. Depending on our testing methods and diagnosis, we can actually decide if the patient needs to be referred to an ENT for a medical related hearing issue, or if they need to have the hearing rehabilitated via amplification, that is hearing devices. The consultation methods have minimum test protocols, including air conduction, bone conduction, and speech audiometry as a standard. Most audiologists would also perform speech and noise test. It is mandatory as per the KPIs set by the Australian government, the Office of Hearing Services program, to obtain COSI, which is client-oriented scale of improvement. So the COSI goals are obtained at the assessment appointment, and it is a must because these will be validated at the post-follow-up hearing aid fitting appointment. Fitting methods also need to have a method of objective fitting, as in real ear measurement and speech mapping. I would love to join this discussion in live and answer or provide my inputs with the flow of the conversation. But from my discussion with NK, I think this forum was to discuss the hearing aid dispensing protocols in various countries. While I cannot comment on the quality of the hearing services provided in India, particularly the audiology, particularly the hearing aid dispensing, because I worked professionally in India for a minimal amount of time, I can say with confidence that we provide a very high quality of service for the hearing aid buyers in Australia. And even the follow-up methods and the auditing methods meet the standards, which I would say are very high. Thank you.
That was Leo Dias from Australia. And so I think we went around the globe to look at how hearing aid is prescribed, dispensed to patients. Now, I'm going to ask a question to the practicing audiologists here. Have you come across an unqualified professional prescribing, dispensing, selling hearing aids? Yes or no?
Yes, of course. We have come across.
So that's
Actually, we must understand from the history of how hearing aid has been sold in our country. Okay, so before we all came into existence in India, audiologists, before the colleges and before everything, there were a few sellers. Especially in Chennai, there was a company called the Modern Radio Company. They used to sell hearing aids in Sandy. You go to marketplace, make dum 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 dum. and I invite the patients and fit hearing aid. Then afterwards, they had representatives going throughout the country by train, staying in different places in a lodges or in some other place, going and seeing doctors, giving advertisement in the paper, and then inviting patients to his place and fitting hearing aids. This was happening. Then once the courses came into existence in India, we had the All India Institute of Speech and Hearing and BOILR Hospital, Mumbai. When we came out after our education, we were employed, but still the dispensing has been done by only trained people, trained representatives of the company, hearing aid company. In those days, it was only analog hearing aid. We used to have economy, superpower, extra superpower, like that. We had only the pocket model hearing aids. Then slowly, later, almost 90s, the digital hearing aids came into the market. By then, we had quite a number of people coming out of the college, working in different places. But still, if you see the ratio of audiologists, even in 2018, audiologists and hearing impaired, I think it is about 1:90,000. We are catering service to 90,000 population. I mean, 90,000 population of hearing impaired in our country. So if you see, look into the ratio, how much we are serving, for how many people, still we have dearth of audiologists. So that is why there is a lot of other people coming into the game of dispensing, selling hearing aids, things. Now there are a lot of regulations coming in India also, and Isha also has put a lot of regulations. You have undergone the training. Whenever the company comes into existence or whenever they bring a new product, they come and teach us. No, mostly we learn from the companies, their representatives, not from the institutions. Institutions' basic education only is being offered. Then we learn it from the companies and their representatives. This is how it is being happening. Even now, more than 60%, 70% is being sold by only the other people, other than audiologists. Dispensing is done by other than audiologists.
Great. Could I ask Dr. Manke to share her experience, if she's aware of the so-called unqualified professionals selling hearing aids?
Yeah. Yes, the hearing aid market is in the hands of non-audiology group, whether it is ENTs, diploma holders, certified people, technician, whatever, you name it, that's there. Now, I'm not justifying that group, but I'm speaking on behalf of hearing impaired individual, okay? He is in need of some device. And if we don't reach out to those people, somebody else is going to take that space.
Yes.
If you really look at the optometry field, how that got evolved. Early days, eyeglasses were sold in the open market and Mela and everywhere, because you just go and check whether one glass works out or not and all the other thing. From there, then it started a certificate course and diploma. Now optometrist needs to be a degree holder only. But optometrists are now 60,000 plus in the country. So if you look into the beneficiaries who need the whole device and the service provider, so-called qualified, it's such a odd ratio. So somebody is going to jump into it, So That's one way to look at all those things. It's we who have to really, professionals need to change our mindset. I'm very strong on academics program. Like, they feel that hearing aid is no good. Hearing aid is commercial activity. Hearing aid is a business. And we are service provider. We are socialistic people. That's how they're groomed. So the hearing aid always gets a negative feeling during the course time. Secondly, the training programs are so much geared up about the pediatric population. Oral rehabilitation to pediatrics, but oral rehabilitation to adult population is not explained, taught, practiced at all. And even if you go with WHO norms, standard like 450 million hearing impaired people worldwide, out of that 91% are adult population and 9% is pediatric. I'm not putting down pediatric work or pediatric population. That's our responsibility. We need to do that. But we need to be empowered to handle adult population also. We are weak in that, and somebody is taking that opportunity. That's how I'm looking at it. So we are surrounded by non-qualified people. Every city, every place, whether it is metro, it is A city, B city, C city, everywhere. Now, how we come out of this, what should be the roadmap? That what something all the senior people, Isha, or professional ourselves also, we should be talking more about that, how we will come out of this whole mela, but there is no point pointing out to each other. Now, this is a reality, and we need to change the scenario. Am I committed to do so? And then you will get the answer. Thank you.
Right. And Dr. Nagaraja has a point.
Yeah. Am I audible?
Yes.
Yeah. I agree with Kalyani Manke. Because when we started, we were to cater to people who cannot afford to buy a hearing aid. That fact is true even today. Who you are catering to as a private practitioner are people who could afford to buy a hearing aid. And the government is responsible for people who cannot afford to buy a hearing aid, and therefore within their means they try to provide what is possible. That is one point we should not miss on. Second point is why social needs are to be met and taught in the courses. Most courses held at national level institutes are to be governed by social needs. The colleges which are in private, they themselves dispense hearing aid and they look at commercial angle. Okay. So there are a dichotomy from where you have passed out. People who are passing out from the national institutes and well-established non-governmental organizations generally take the stand of preparing the student to take a social angle, not a commercial angle. Okay. And in any profession, whether it is ENT, speech and hearing, when commerce come in and people invest in their practice, they want to get the returns back. Therefore, there is a wide gap between professionally correct practicing and meeting the investmental returns to the practice. Okay. When we discuss about DHLS, I will talk about this again from the point of view of what is the role of government. Okay. And second thing, has it not been discussed in RCI itself? It was discussed whether there should be a certification course for dispensing in hearing aid. Doctors, ENT specialists, people from the industry, and audiologists and expert committee, subcommittee of the RCI discussed this, and it was felt that RCI is not an appropriate body to conduct this examination, and how to force people to make them take this examination became the issue. and after that it was not implemented. Thank you.
Great. Thank you very much. Could I ask Mr. Taranbir Kocher about his experience with so-called unprofessional people, unqualified people?
Okay, so I vouch for Dr. Manke's words, but if I look back, in '96 when I was one of the first audiologists hired by a corporate in India, the scenario then was totally different. We had only about 300 so-called hearing aid centers where people could actually get a proper hearing aid fitted to them. And with the industry growing at that time, a lot of multinationals coming into India, the manufacturers were left with no choice but to start training people to start fitting hearing aids, because what could you do with 300 centers? How much business could you actually get from it? So we conducted a lot of training centers, training courses at that time, where we identified people who were audiologists, or people having some experience in hearing aid fittings, or even people who were new to the field, entrepreneurs who wanted to get into this business. So you could actually blame me for many of the unqualified professionals fitting hearing aids, but then that's how the industry grew, and even the market grew, because we could make hearing aids accessible to people who never had any access to them before. So yes, there are unqualified professionals fitting hearing aids, but at least they have gone through some certificate course or a training course which has enabled them to fit a hearing aid. And we all know hearing aid fitting is not actually rocket science, but of course the rehabilitation which comes post a hearing aid would be something which only a qualified audiologist would be capable of doing. So even though the scenario today is that there are more unqualified professionals fitting hearing aids in India, we still can be assured that probably some of them may be doing a better job than what an audiologist would do in fitting a hearing aid. And that's my view.
Right. Um, to Ms. Seema Rupani, have you noticed any of these professionals back in your country?
You mean the unqualified that they were talking about? Yes, of course. I think there is this gap that Taran is also talking about. We have a large unmet need of people who need the hearing aid devices. I think ultimately we've got to figure out, we've got to adapt as an audiology professional. We've got to realize that there is going to be things like artificial intelligence, telehealth. There are going to be different requirements as the awareness in the general population grows. We have to change our views and say, well, we can't be, yes, I follow best practice. And yes, that's what's going to be for the very top level of patient who is also willing to pay. Let's not forget, hearing aids are expensive. Everybody's shied away from the dollar sign, but the top hearing aids are expensive, and a large part of that expense comes because there is so much follow-up and rehabilitation required with that hearing aid. I think it's sad when people sell the hearing aid for the same prices and don't offer the very best level of services with that hearing aid. However, what happens we're still just, I think the global figures say that we're only fitting 1 in 5 people who need hearing aids. It's probably only 1 in 10 people who need hearing aids in countries like mine. So 90% of people who require hearing help, whether it's hearing aids or something else, 90% are not getting it. And we've got to recognize and accept that we need to look out. I mean, I'm on a desperate hunt. I'm going to get off my high horse and say, yeah, I don't think it's just the fully qualified. If it's going to take 10 years of training to train one person who probably fits a couple of hearing aids a year, we're never going to meet this need. So we will have to look for alternatives. We will need to look for alternative models. I think what we can do as the audiology profession is own that, accept that, and then create standards of requirements and education and awareness in the population with a hearing loss, what they should be looking out for when they do try and obtain such services. And as long as they're looking out for a minimum, I don't have wax in my ears, I don't need to see an ENT because of a hole in my eardrum, if they're aware of these things, or for example, I have dizziness and I have a unilateral hearing loss, I should be seeking a medical professional. So all these referable conditions, is if there's awareness, I think there is something to be said about obtaining a lower cost device. I don't know how it works out, but there will be, it will come in. And we've just got to figure out how we adapt to that, and we, we change our importance to the other things around that device. As Sujata was saying, it's much more about the rehabilitation but we're going to need to go through a change for sure.
Right. Thank you very much. That makes sense. I'll go to Sugata and ask, do we have any such unqualified people in the US who manage to sell hearing aids?
Well, there is, I mean, they have to have a license. There's nothing, there is nothing called unqualified. You have to have a dispensing license to sell. But, I've seen a spectrum. And, what will amaze you, the biggest dispensing center in US now is Costco. Costco is a retail, it's like a similar analogy of India would be Metro Cash and Carry. It's a wholesale place. You go in one corner, they have, you will be amazed. There's a 60-40 split. They do hire audiologists, but they have 60% dispenser. But the fitting protocol they have, they may do a crappy job, a disastrous job. But if you see the protocol they follow, there's a questionnaire, they do a fitting. Each office has a verifit. They verify every fitting. So because they are a large corporation, even though they don't do a good job, they have a protocol, and whoever goes and buys the product from there comes out when they walk out, they have a higher level of satisfaction because they pay less, but they are coming out with every possible verification thing. Whereas me and Gus Mueller, we did a survey, and only 20% of dispensing audiologists in US has a verification tool. They don't have it. So what Taran is telling is not incorrect. I have seen both ways. I have seen extremely talented, qualified audiologists doing a disastrous job. I've seen somebody with a diploma, with a dispensing license in US doing a fantastic job. And the cost is a different issue. I think we started it wrong by bundling the cost. We should have never bundled the cost. I think the cost of hearing aids should be separate. The cost of service should be separate. That is the problem. What is interesting is we have two academicians here. I have Dr. Nagaraj and is Dr. Nataraj there too?
Yes.
So I have a question for them, sir, if you are hearing me. I mean, why is the social angle so strong? I mean, doctors go to learn medicine. Why are doctors not taught that you go and be a social provider than a profit-making provider? If I could get Dr. Nagaraj and Dr. Nataraj's input. I mean, is it because historically it was a government program? Was it that? Or I mean, why are we not? I won't say the word commercially, but why are we not coming out more business savvy?
May I answer this?
Yes, Dr. Nagaraj, please.
The question was pointed to us and Nataraja.
Yeah.
In one way, you yourself has answered it, that we were part of government and it was mandate. We have to follow. One. Second thing is your observation that Doctors are not told. No, in India it was social medicine earlier. Only very recently it became commercial medicine. Doctors were considered as gods, and whatever they say is the truth. Second thing is the social angle came from ENTs also. The earlier to the speech and hearing courses, there were audiometry courses in conducted by ENT specialists and who thought that basic dispensing does not require much of training. Second thing, selling hearing aid for commission or for money was considered wrong as it is a service field and we should be giving service. Now that thought has changed. Institutions which are training people are also making it very, very clear to people. You practice, but practice correctly.
That's
Practice and you earn money, but do it correctly. For example, the greatest failure in making people who buy hearing aid use is not because of the dispensing part, but because of counseling and follow-up part. As you yourself have said, in a developed country where you are working, if the follow-up is so poor, how do you expect in our country the follow-up will be? A idea is given after you buy this hearing aid, everything will be okay. They don't think about counseling them on, look, hearing with hearing aid and without hearing aid are two different experiences for which you have to be trained. Listening training is something which is not done everywhere when dispensing, and counseling is not properly done. Counseling is given, if you buy this, you will be all right. That word, you will be all right, is not correct. Okay. Second, legally, even after buying, if you are not satisfied, hardly few people think about going into questioning the seller. Okay.
right.
They will go to different people. Some people say this is not programmed properly. I will program it again. Some people say, why should I program a hearing aid which is not bought from me? So you buy a new one kinds of. So these small nitty-gritties have to be looked into by people who are practicing. That's why when Kalyani Manke asked me to be practicing audio, I'm not a practicing audiologist at all. I have never sold a hearing aid. Okay. I taught about hearing aids, about oral rehabilitation in courses, and taught what the audiologist should be doing. Okay. But this is also bread and butter case. A practicing audiologist has to survive. So to survive, you charge whatever you like, but whatever you charge, we don't say how much you should charge in course. What we say is practice, practice ethically, and if you are charging something, serve for that. That's my answer. I don't know whether I answered you adequately or not.
Yes. I have one question for Dr. Nataraja. Sir, you have a private teaching institute. You have more flexibility. Why don't you introduce a course which teaches the people to be like a business course? I mean, to so that they learn something about entrepreneurship, because you have that ability. Have you ever thought about it?
Meanwhile, Dr. N.P. Nataraja is the director of JSS Speech and Hearing, Mysore. Welcome on board, sir.
Thank you. Thank you for involving me in this. Well, first, I would like to answer what Sugato has been talking about. I think the social service has remained as a theory rather than practical, in my opinion. Presently, as I have observed, the trend has been as soon as they pass or even before they get their degree, the people are employed by many private business people. And they have been given a good salary. And of course, the main thing is they are given an extra commission on the basis of the business turnover that they make. In the sense, if they sell a hearing aid which costs more money, they will get more commission. So this has been the trend. And particularly, I can give you several examples in Bangalore. And therefore, the even though the so-called qualified professionals become unprofessional in the sense they start doing unethical practices to get more money. So there is no question of social service involved in this. And even though we keep telling that we should serve the handicapped, and how many people we can find, how many professionals we can see, even the audiologists who are supposed to be taking care of the educational audiology are involved in taking care of the hearing impaired children, or even other kinds of rehabilitation of the adult hearing handicapped. It is very, very few. Many of them, or majority of them rather, go for the business, that is selling the hearing aid, not even prescribing. I don't even like to use the word prescribing, because they're not prescribing. They're just selling the hearing aids. This is a very disturbing thing that I have noticed. Particularly recently, it is becoming more and more. And many hearing aid companies have been employing people and doing this. That is the unfortunate thing. And you asked another question about the course. Yes, if we have not been able to teach them in 4 years, how can you expect us to teach about the ethics or hearing aid prescribing within a short course? I don't think it is a feasible thing. As long as the hearing aid carries a lot of money. I was told that nearly 80% or nearly 80% profit one can expect in hearing aid business. I don't know how far it is true. At least as I know, definitely it is around 50 to 60%. So when money is attached to that, or a lot of money is involved in that, that leads to most of these unethical practices.
Sir, let me rephrase the question. What I wanted to know is maybe teach them to be a better entrepreneur. That's all I was asking. And I think what Dr. Nagaraj said is very correct, that it doesn't matter how much you charge as long as you can justify what you are doing. Right, Dr. Nagaraj? Am I correct?
On me?
No, Dr. Nagaraj said that it doesn't matter how much you charge as long as you can justify.
Even after that, how much time people or the audiologists spend in counseling the patients is very important. That we have been emphasizing from the beginning. We have been telling that the counseling or proper use of hearing aid, all this becomes not just prescribing and leaving it at that level. Even though theoretically we keep talking about it and we teach that, but once they get out, they don't practice those things. That remains only as a theory, rather. That is my experience. I'm sorry, I'm not really involved in audiology practice. I've never practiced as an audiologist or even as this one, except for some clinical work that I've done as speech pathologist. Otherwise, I don't have any experience. This is what I've heard and I have learned from other people within the profession, outside the profession. I know it will hurt somewhere that we are getting into this kind of practice, but it is unfortunate. So And definitely we do find people like the electrical shops selling the hearing aids, even next to the speech and hearing centers. I can show you, even in Mysore or even in Dharwad or even in Bangalore. Like that, I mean, they have been doing it. And even, I know Dr. Nagaraj mentioned about one of the meetings of RCI, even which I attended along with him way back in 2010, where we discussed about providing certification to the people who are working in hearing aid industry as sales representatives of hearing aids. And of course, that did not work at all later. I mean, I don't know what happened. Later, nothing has been taken up on those lines. This is my experience with reference to hearing aids.
Thank you, sir. Seema Rupani, you have a point?
Yes, I really wanted to come in there because so I've seen this from an education in India, in the UK, and then starting private practice. So where I do agree with Sujata is that I think having some business skills allows us to actually become more ethical in our practice. For example, I think unfortunately it's this performance indicator of how many hearing aids do you sell. That's a wrong indicator. I think I use an indicator of an important piece of data that we get today is the data log. We can look in a hearing aid and see how long does a patient use their hearing aids for, how many hours, or how often, how many patients actually come back to me for their second hearing aids. So changing your metrics as to how you gauge the health, if we're looking at audiology as a business, how do I gauge the health of my practice? If I put my key performance indicators correct, I can actually do a very good practice, a very profitable practice, but a very ethical practice too. I was smiling because it's so, I find that the people, I have an interesting market in Kenya. They come to India. I have patients who come to India. They come in for their regular health checks, you know, the gold executive health check that you get in these hospitals. Before they know it, as part of that, they've had a hearing screen and they've had a hearing aid sold to them, and they're back in Kenya within about 3 days. And then they're calling me to say, well, I don't know. I've got this hearing aid and I really don't know what to do with it. I don't know how to use it. It doesn't really work for me. And here I've gone the other way. I'm probably known as one of the more expensive audiologists, but I think, as what Dr. Nagaraj was saying, is if you can justify the service that you provide with that, I find that I don't actually shy away from saying, I'm never going to be able to compete with Indian prices, forget it. I just don't get the hearing aids for anywhere near what India gets. But if I provide the very best of services, the follow-ups, and I check that my patients are wearing their hearing aids, then I've done a good job. So I do agree with Sujata that I think we need some sort of ability to look at this business as an ethical, sustainable business, rather than just greed and the selling of a device.
Great. So when I have a hearing loss, I'm going to fly to Kenya, Seema.
Yeah, there you go.
Suman, could you share your experience with us when it comes to this topic? Is Suman? Yes.
Sir, I agree with the Sugatu sir and Nagaraj sir, where they mentioned that there has to be balance between what we provide and what we seek. So, service and the cost should not be matched, because in my experience, I have seen that people are referred to a government institution after having uh, done all the investigation for getting the hearing aid, and investigation or assessment takes a lot of money, or they charge a lot of money, and then once they are done with all the assessment and there is nothing left there, they are sent to the institute. And that is one part. Another part is that if we are providing services, we have to charge. There is nothing wrong in charging for our services. And with regards to follow up, there has been an issue due to the maybe the high caseload, or people are not aware uh, about the need, or they just don't want to invest in such a uh, I would say it is one of the valuable things to do. As Sugato sir was saying, that there has to be a follow-up verification about what we have provided and how the people feel. But over here, the follow-up is very limited. What I see in my experience, I'm not able, I cannot point about others, but in my experience, we have two uh, different angles, and we are catering to. And I think there has to be one course, not two course for the. I would say it is prescription and dispensing. It is not only just selling the hearing aid. If we consider person with hearing disability or hearing impairment into consideration.
Great. Karan, any words before we switch tracks?
Nothing, nothing different from what everybody has said. But I think for India, what is crucial is that we definitely need more fitting points. If we compare with a country like Germany, which boasts of almost 5,000 hearing aid shops, so-called, catering to such a small population, and given the population of India, I mean, we are nowhere close to it. My last count was about close to 2,000 or 2,200 approximate fitting points. So we have still a long way to go. And if we continue to depend only on audiologists to start a private practice, then this is going to take years. So definitely we need to have some kind of a certificate course or a training course for people for hearing aid dispensing, just like optometry or something on the similar lines. Yeah, that's it.
Thank you. I'm going to read. Yeah. Yes, Vinay.
Yeah, I just want to add to what I was just sharing. We have about over 10,000 audiologists registered as on date, 10,000 plus, and we have about 66 bachelor program going on in our country. So we need to rationalize before we open up, because monitoring or ethical practice is a big concern in India. I am not aware about other places, but ethically and implementation of the guidelines is a big issue. So I think we need to rationalize before we open up uh, to different perspective, at least in terms of hearing and dispensing or any other issues.
Thank you. Before we switch tracks, I'm just going to give a shout out to all our audience who are there on live chat. Mr. Narendran Krishnaswamy from Coimbatore has agreed that oral rehabilitation should be addressed fully beyond just prescribing hearing aid. And we have a question from SK Radhakrishnan. There are several companies that sell over-the-counter hearing aids that does not require any prescription or testing. It is like buying reading glasses in the store without an eye test or prescription. Now, anyone to talk about these so-called hearing aids or hearing devices that have been disguised as hearing aids, especially in the online market? Anyone? Yes, Dr. Manke. Unmute yourself, please.
Yeah, online market was initiated by these companies, and then they realize it has bounced back on them. Now they are monitoring a lot of things. A couple of companies claim that their product is not online and all. So it needs to be seen differently. But like 3-4 years ago, means people walking in with us and showing that, this is online product, this is at this price, and we don't want to buy from that. That number has drastically come down now. Okay. So mindsets are changing. And if somebody says that hearing aid cost in this is at X price or Y price, I always tell choice is yours, what you want to do with it, because 10,000 and 5,000, 50% of the price we cannot compare at all. But the hearing aid is without warranty. Hearing aid is not programmed from somebody's cupboard to your ear. Is something, so these kind of information or dialogue or something needs to be initiated as and when we get that opportunity. There is no point blaming, that online is on and stop this and that. I take every incidence as an opportunity that I want to tell them that there is some difference. There is thin line between the, service and that product. And what do you want? But other thing, we talk about ethics all the time, but I'm sick of all that. The whole India is in idealism, but who is ethical from top to bottom? What is happening? It's way of life now. So why, what is happening in politics, what is happening in business school, what is happening in medical schools, what are the things are happening? Why SLP should be ethical? Because they are seeing the world differently. They are seeing, perceiving, and then it's preaching them, be good, be good, be good. World may be different, but be good. This is not going to happen. We need to have good role models, and gradually things will change. It's like early days, like Nagaraj, Nataraj and myself, where we learned that, all idealistic things. Then in 80s and 90s, that rebellion role came. That's why Amitabh, angry young man, showed that, how things are. I don't buy this and I don't buy that and all other things. The world is changing. Now USA also has shown us, what it is money can buy and money can do and all other things. So I think instead of saying is, too much of ethics and too much of idealism, it's right. Professionalism need to be taught. We should be talking about the profession, professional services, and who should charge 1,000 rupees or 5,000 rupees or 500 rupees is an individual choice. And whether I want to pay, you see the medical doctors have varied charges, lawyers have very different charges, dentists have different charges. So why do you want to keep all rules for us? And that's what people don't like, and then that's why they rebel out. They say everything yes on the platform. That, in Isha conference and Misha and all other thing they will say. And those are the people practice wrongly outside. Because we all have two faces, and because we don't have good role models. That is the whole thing. And that's what we see, the unrest among the professionals. So now we have to change our gears and talk about something more about how I'll get peace of mind what I'm there as such. Why do I feel so uncomfortable about being in this business? Why I'm so uncomfortable and minding somebody else's business? Why do I can see myself and show it, what we want to do. Thank you.
Thank you. The next question is from Mrs. Raji Indirasan. The question is, can we buy hearing aids without prescription? And I think what she means is it like medication that you take without prescription and something serious could happen? So could one go wrong in buying a hearing aid without any prescription? I shall ask Mr. Manoharan to answer that.
Yeah. See, it's being sold like that in many places. Just like that, go and get it fixed. Or even sometimes, the parents are somewhere in some villages, 80, 90-year-old, you cannot bring them down here. They won't have even had their hearing tested. They would say that, we have to shout like this. So he requires a hearing aid, something you give. So such kind of things are there. It's being practiced. But the thing is, okay, they sell it. If it is not suitable, do they take it back? If it is not suitable, do they change it? If it's not suitable, do they adjust it? That is the main problem here. Okay, even if they sell it, they should be able to provide service, proper service to the patient.
Great, thank you. Mr. Narendran adds to his points that patient-centered approach or patient satisfaction should also be counted and added to the practice. Now, changing gears, time and again, when we talk about unethical practices or unqualified professionals entering the business or selling hearing aids or prescribing hearing aids, we talk about the diploma program in speech, language, and hearing sciences. I am going to ask Dr. N.P. Nataraja to throw some light on this diploma program, how it all evolved, and what was the purpose. And Dr. Nagaraja could also add to that. Dr. Nataraja, please.
Yeah, probably Dr. Nagaraj will be a right person in the sense he has much more experience in diplomas than me. I mean, of course, I still remain as a person who opposed it from the beginning, and still I continue to oppose. But now, I mean, I still in a very puzzled state in the sense about our, I don't know who is doing this. Then on one side, we are saying we require people with just 1 year training. And on the other side, we said 3 years is not enough for a bachelor's degree. They do not get enough clinical experience, and therefore it should be extended to 4 years, and they extended it also. I mean, these two things are really very going in opposite direction. On one hand, we're saying 10 months is sufficient to train diplomas. On the other hand, we are saying 3 years is not enough. That is the case. And what we are producing, what we are expecting from them, of course, just now we had the discussion about hearing aid. And from that, it goes that there are a lot of people who need the help of the qualified people to help them, or the speech and hearing handicap in the country to be helped. So if that is the case, yes, one has to accept diploma. But at the same time, it is not stopping at that level, just like the hearing aid selling, even the diploma people have been doing all sorts of things, and they're going beyond their limits. That is what. Of course, it all started somewhere in 1984, 85. In one of the Isha conferences in Bombay, we had a very big discussion. And of course, some of us started fighting against the people who wanted to start diplomas. And of course, we were nobody in the sense, we were all just chotas. So we could not withstand their will, rather. They wanted to start and they started. And of course, I heard that there are nearly 250 centers in India which have been providing this diploma course. So that means they have been producing diplomas. I don't know the direction in which we are going. As Dr. Manke pointed out, I think the role models or the leadership in the profession is lacking. That is where we do not know the direction in which we are going. At least I am confused about the direction in which we are going. Of course, I'm on the verge of my retirement. It doesn't really make much difference if I say this is good or this is right. But then somewhere it bothers me. You know, in spite of all these, even after spending 55 years, still we are not settled and we are not sure of the direction in which we have to move. That is my experience.
Yes.
Thank you.
Can I?
Yes, you can.
Well, all of you can blame me to be a spokes in the wheel for starting this program. The National Institutes for the Disabled were started in 1983 with the suggestion of experts saying that the institutions under health ministry are not able to cater to disabled people, and social welfare ministry was entrusted with the responsibility of providing services to the disabled. Okay. So Oliver Jung National Institute for Hearing Handicap was opened with a mandate to provide services to the disabled persons. Okay. There was no PWD Act, there was no RCI. The existing institutions then were turning out. So in Bombay, it was still a diploma program at Nair, and later it turned into graduate program. All India Institute of Speech and Hearing started as a graduate program. So in 1984, the Executive Council of the Oliver Jung National Institute of Speech and Hearing, AYJ-NIHH then, decided that AYJ-NIHH, the first priority should be manpower development. And under that, the discussions took place with the expert committee at the ministry, in which Dr. Ratna, Dr. Kakkar, and others also participated. They discussed that what should be this one. There were 660 districts then in 1984, and except for megacities, there were no facilities of in other districts other than the city. Okay. So therefore, the question is, how can you prepare to provide? At that time, it was 3.2 million hearing handicapped people, to provide services to them. Okay. Hardly 5 institutions recognized as Danish aid in 1975 got Danish hearing aids to be distributed under the government scheme for people who were below poverty. Okay. Then the government introduced hearing aid dispensing as a policy from the ministry. Who will do that was the question. The questions was directly asked. I was called to answer in the ministry to how I'm going to, because at that time the director was A.K. Mukherjee, an orthopedic surgeon, who was looking after Haji Ali Institute as full-time director and in charge of AYJ-NIHH. They had not found the right person to be the director of AYJ-NIHH then. Okay. So as Deputy Director Technical, I was called in the ministry and asked. I told them BSc Speech and Hearing, which was 3 years then. They said, we'll wait for 3 years for people to get that. Already we are late. Suggest something which works. And they instructed me to start 1-year diploma program. It was instruction. It was a policy decision that we should be. So we did the mistake of developing something called DMCD, Diploma in Management of Communication Disorders, not DHLS. That title, management, attracted graduates to, in the first batch there were mostly graduates from Gujarat and other places who took up this program. Okay. And we had to push in not just the hearing aid. Hearing aid was one aspect. We had to push him and train them in 1 year on rehabilitation. not on hearing aid sale or hearing aid prescription, etc. Hearing aid was a part of it. We had to do. So at that time, they were called diploma holders and they were called speech and hearing assistants. They were not assistant to a senior audiologist or speech therapist, etc. They were assistant in the same sense as medical assistants, healthcare assistant, etc. Cadre wise. Okay, and they would be working in ENT and other hospital setups. Okay, so therefore the concept there was rehabilitation. Okay, and hearing aid became a part of it, and they wanted to meet as large as possible. So AYJ was told not only to start the program, but to pick NGOs who can do it and support those NGOs. Okay, as rightly pointed out, this was opposed by Isha, myself, and Dr. Ratna, who joined later as the director in 1985, had offered to resign on this basis. We did not have choice. We have to cater to government. Do not think about audiologists or someone. They think about people who they cater to, and they ask institutions which were started for that purpose to do that work. And that was how the course was started.
Okay. How do you think that this particular course that started with good intentions has changed track, or how has it affected audiologists who are qualified undergraduate or master's or doctoral level programs? Anyone?
The answer is, I had suggested this also. The mistake that we did was we brought people from district level and made them get trained in mega cities. They got adjusted to city life and they could immediately get jobs under ENTs and they settled there. They did not go back to districts. The purpose, the objective of starting program was defective, and I went back to ministry and fought with them that this training should be shifted from national institute to smaller institutions who are catering, and when selecting, we should select people who have the landed property, etc., who would for that reason go back to those places and start working there. The shifting happened in continuation of programs at the regional centers and the national institute, and also wrong NGOs picked it up. Even without giving training, they started selling their certificates. Okay, the government fund was misused there. Okay, people who went to inspect the institutions, whether they are fit or if they are having the facilities or not, did not go through the process of correct inspection, and it happened quite a lot in North. Okay, so therefore, nobody can be blamed for this. And second point that I would like to stress on that is the DHLS, etc., who are working and selling hearing aid also provide therapy, which the graduate audiologists, postgraduates do not do. They sell the hearing aid, they prescribe the hearing aid, they don't give therapy. Therapy and the practitioners are SLPs, not audiologists. Many of my students at AYJ are excellent therapists who have established their clinics in Bombay, etc., and doing wonderful job. Okay, but they are not audiologists. They don't prescribe hearing aid. Those people who are fitted with hearing aid or cochlear implant goes to those clinics, can get the help. And such clinics are available in even rural places, not very, very big one. Okay, so it's a kind of a fight between sharing of profits. The graduates feel they are deprived by diplomas in big way from what they are getting. That is not true. You would not have gone to the district. You could not percolate down to that level. You wanted to practice in your cities only and make money there. Nobody is competing with you. If you can go there and do it, who is stopping you from going there? Nobody is stopping. You don't displace in city. So that is what is exactly is happening, and that is not the right attitude to take. People need to get services at this one. Second thing was, we always told that all that is required for identification, diagnosis, and fitting at primary level need not have to have an expert. Do not people, this question was raised when the curriculum development was taking place. Do not, people who live in village doesn't require a postgraduate. He may require, but what is the priority? 3 in 1,000 births require serious consideration for oral rehabilitation. Okay, and those 3 or 4 in 1,000 are not in each village. They are distributed. Each village cannot get an expert or a center. When government plans, they plan it in a way that the facility could be provided at different stages and covering different population. The coverage they see, they don't think at an individual audiologist level. Okay, so therefore functioning is different, coverage is different, and the organization accordingly is different. Government institutions get budget from government, whereas non-governmental organizations have to earn that money to sustain and be in the field. That's it. Okay, I think I touched upon some points which others may not like. Thank you.
From the audience, I have Nooreen Alam asking a question. Why is our association, and I think he's talking about Isha, why is our association not aggressively pursuing stopping DHLS now?
Well, I will answer this. Nataraj can answer. Suman can also answer. Okay. Isha has raised it, even Kalyani can answer. This we raised it several times. When you are not allowing diploma holders to be members, you have no business to stop them or do anything. Second thing is, Isha is a barking dog, not a biting dog. You have no legal authority at all. You have not been attached with any government organization. At government level, you are not at all recognized. You are a registered society. At best, you can file a case, and we have filed cases and lost it also in some places. Okay, that's the explanation that I can give.
Okay, how about yes, Dr. Manke. Please mute yourself.
Sorry. Yeah, sorry. Couple of things. 20 years ago, the manpower requirement was projected, and that's how this program had started. So that's okay. There is nothing wrong in it. You know, Isha has absolutely no role in DHLS in that sense, because as Dr. Nagaraj has said, it's an association. And we mind our own business, what is in our house. We cannot say what's happening in neighbor's house. So people always forget about that. But speech expert committee in RCI has a big role, because expert committee has developed this curriculum. Expert committee has said what is to be delivered to the DHLS. I have this page here. What is the aims and objectives about this whole DHLS program? Now, expert committee need to revisit also, because it says aim of the program is to train a class of person and equip them with basic skills of providing speech and language. Now, that basic word is very ambiguous. What is minimal? What should be taught? And then in objectives, everything is said. Provide basic clinical services of assessment and management, provide speech and language hearing evaluation relevant to management, and all other things. So hearing aid is secondary. That objective was not there. But when you can't earn anything in this therapy program, naturally somebody is going to look into lucrative business. And that's how they came into hearing aid. Because if therapy does not generate a revenue, something else should be done that way. Now, when Suman had said or quoted that RCI registered number is of 10,000 professionals, that means we are marching forward, we are doing well. Now I need to urge, or I want to tell Dr. Nataraja is in expert committee, give a proposal to stop this program in next 5 years or 3 years time. This is something is essential. The need was there. We started. Now we see it differently. It needs to be revisited. If you remember, there was a program of DMLT, lab technician, diploma in medical lab technician as such. Those were the people were doing a pathology test and all other things. Now that program is debarred because there is no more need for it. Same thing in optometry. There is no certificate course and no diploma course. Who did that? Their own body. So we just criticize, we blame, we say, but we don't act upon it. Expert committee can bring the pressure on RCI and then say that revisit this whole concept, revisit. Outsiders can't do anything. In court of law also this will not stand anywhere, because suppose I am a diploma holder, I am a licensed person because I have a certificate, I'm registered under RCI, I have a certificate. What does it says? Management, intervention, diagnostic. You read all the curriculum. I have studied all that 5 papers and everywhere. Now, minimal information, this much information doesn't make sense. You use all those words, differential diagnosis, intervention program, strategic planning. That means you are giving me authority to serve in that capacity. So we cannot stop those who are practicing in the country right now. But we can narrow down the number and then eventually we can close or redefine it totally in different ways as such. Okay, that's my feeling is there. And needs do change. You know, what was 20 years ago is not applicable today. What is today, we are seeing it, probably over the counter sale of hearing aid will kill everybody. So 5 years from now, we'll have another panel discussion about how to cope with, over the counter sale hearing aid as such. So this is the dynamic, is changing environment. How we adapt to it matters more to than anything else. Thank you.
I would like to respond. I don't know whether I still continue to be the member of the subcommittee on speech and hearing of the RCI. Dr. Nataraj is also there. And the meeting took place 2 years ago. And thereafter, the meeting itself is not called. If the meeting is called, and if by chance I am continued, I will raise that point. Thank you.
Thank you very much. Anybody else about DHLS program and what you think about this program affecting your profession?
Nandu, you can use statistics to your favor whenever you want. I mean, the whole numbers thing, like the whole way that the corporations pushed the hearing aid accessibility bill in US, which will basically legalize over-the-counter hearing aid, was by just throwing numbers that, this is this huge amount of people, those who need to be catered. This is a small number of audiologists, and they can't get access. That's not true. But you can use statistics to this. And even as far as the doctoral program in US is concerned, when Dr. Goldstein brought the whole doctor of audiology thing to make audiologist as par with the doctor of optometry, the online courses started, and they were supposed to be there for a short period of time to bring that bridge between people who had masters and that. But not every program is shut down. So in the same way, when a program, when a program starts, it's very difficult to roll it back. And we can propose, but unless you have a power of authority, you can't do anything. I mean, it is just not possible. We can give, even as a member of AAA, Dr. Manke was in my team. We used to give a lot of proposal, but all we can do is, even in US, we can give proposals. Nothing happened. I mean, when the hearing aid accessibility bill was being pushed, for the first time, AAA and ASHA, two bodies, those who fought for years, came together, but even they could not withstand the power, because you had corporations who were funding all the legislator to push the bill, and we could not do anything. So that's the truth.
Now, in the US, we do have a diploma program, or we call it as speech language pathology assistants. How is that different from DHLS? Dr. Manke, I think you have experience in reviewing these two. So could you throw your thoughts about the assistant program in the US and compare it to DHLS and say, why not keep the DHLS go on?
It's interesting. Some 20 years ago, there was a proposal about assistant to audiologist and assistant to speech language pathologist, which was turned down by SLP people totally. And then something in 2010 later, the demand started coming in because the caseload sort of, increased significantly. Mind you, in United States, there are more than 200,000 or 2 lakhs SLPs registered with ASHA. So that's a huge number. Audiologist number is small, I think 14,000 or 16,000. Rest all are SLPs, and the demand came from SLPs. That's okay. Now I have this blueprint. This is something now. It's an official program from ASHA. So audiology assistant exam blueprint. But the most important part about the language which is drafted. So it's not assist patient caregivers in completing case history or other relevant forms. Assist the audiologist in identifying the need for linguistically and culturally appropriate translation. Perform non-diagnostic otoscopy using this. Inform patients the procedure. There's a lot of things are given. It's 3-page actually. But what it means, their role is clearly defined, what they will do and how they will do. In DHLS, we fail to do that. So now we have a huge, wonderful document. It's audiology assistant blueprint is, 3 pages, and SLP is, I think, 6-7 pages. Study that and revisit our curriculum and redefine it. Then probably we will be able to justify the existence of the program. Here we have created our DHLS program as preparing clinicians, and ASHA is very clearly defining is, what they will do and what they will not do. And the responsibility of SLPs or the professionals, their duties is also defined. How will they do the supervision, or how will they would adhere the compliance. So in that case, if things go wrong, it's not only the assistant will be responsible, but the supervisor will also be held responsible for it. That matters more. So I think this document need to be studied by expert committee of RCI and redefine DHLS. Then we can sell, we can justify also manpower development. We can justify that, they will exist, but this is how they need to do it. So we made a very generalized of aims and objectives. We really gave them power to do everything, and now we are shouting at them, which is very wrong. We made a mistake ourselves. Yeah, thank you.
Well, I'll give you one example, Nandu. Like in my practice, I will like to hire some SLP assistants, because the audiology assistant, because when I am done with programming and verification, every new hearing aids come with things like an app and use and everything. If I have a assistant, my power, my hours are not used in that. I can see at the next patient, and the audiology assistant can teach the person how to use the app and other thing. And what Dr. Manke said is very true. If an assistant license is attached to a professional's license, so the responsibility is higher. I think the advantage the diploma holders have is they are kind of an independent professional, and they don't need to be supervised by anybody. So, but once you roll a program, it's very difficult to bring it back. That is the truth.
Yes, and Dr. Manke's point seems valid, where let's keep the program. How about we go back and change based on what the US is following, adding the words like assist a speech pathologist, assist an audiologist, and we curtail or curb their or put a limitation to what they can do so that quality service could be given. Would this be difficult? Anyone with experience with RCI or knowing how to propose this, can we make this proposal so that we reach our goal? Yes, Dr. Nagaraja.
The question will arise, assistant to whom? Audiologists. How many audiologists there and where are they? Okay. Again, we will not be able to meet the requirements of government. Government asks you, if you yourself are not there, who are they going to assist? So if you say that they should be assistant to you, then you have to be there. You are not willing to go down from cities to districts or even lower places. So that question still arises. What we need to do is they have to work as a certain level only. Beyond that, they have to refer them to higher places or higher centers. So the syllabus has to be duly modified in terms of words. And when you have people in the subcommittee who are faculties from academic institutions of government, the problems like, I know this, so it should be there in the curriculum arises. Okay. When we are doing curriculum development, it is not what you know as professor that should be inside the course. It is the level at which what should be there. That is a fight. Those people who have experience, we are alone. The rest of the people are all people who are youngsters and who want to put what they know into the curriculum. So it's very disbalanced, imbalanced programs, even at degree and postgraduate levels. Okay, it needs to be thoroughly modified right from diploma to postgraduate level by properly constituting the curriculum committee, which is to be different from the needs of only government institutions. Okay, government institutions have access to facilities, access to budget, they can buy anything. What are required and what they have is not the requirement of training. So it has to be looked into from very many angles, and RCI should be receptive to it. RCI hears authority by way of people who are having governmental access. So it becomes very difficult at that stage. And anyway, it is the youngsters who have to take it up. Thank you.
Thank you. From the audience, we have Meenakshi Vadera, who agrees with Dr. Manke and has a suggestion. Can we make these DHLS candidates upgrade to graduate level through some courses, I believe, so that the future diploma programs can be curtailed in the delivery system and we can control what we teach them and keep them at the diploma level? That's one question. The other question that I have is it possible to certify them or put it on their certificate that this individual is qualified to practice in, say, for example, Ratnagiri and not elsewhere? Because at least in the US, in the place where you practice, you have to put your certificate where it says that you are qualified or you're certified. And patients who walk in, who's from Bombay, can see that this person is not qualified to work in Bombay and has to go back to Ratnagiri. Yes, Dr. Manke.
Sorry, we can't do this in India because in United States you have state legislations which are define the territory of the practice and everything. In India, I can practice from Kanyakumari to Jammu Kashmir anywhere. So we can't stop that, so because this does not define at all. Other thing is certificate is no meaning. Now these all diploma holders have their RCI number which is displayed appropriately. It's on their visiting card, it's on their letterhead. What they are different from we professional. Our prefix is A when the diploma holders prefix is B. Now for layman, what does that mean, A and B? Nothing. What does he see is it's certified by Rehabilitation Council of India. So he's an authorized person to deliver the service. Now that registration or certificate does not define what he will do, what he can do or cannot do. Secondly, it's not mandatory to display our duties and roles and all, or scope of practice. Even speech and hearing, the Isha has developed scope of practice. That was, we started in my tenure only, we submitted and all. Now RCA has also approved that scope of practice document. It's 20 pages document. Who is going to read that scope of practice and all other thing? Layman is not going to read all that. That's for us. That's for the ENTs. That's for the medical fraternity to know who we are, what we do, kind of thing. So this is very tricky situation. But we cannot just bring the same compliance what is it in United States. That's just I want to tell that. Thank you.
Great. Yes, Dr. Nataraja.
Clarify some of the things Dr. Manke suggested.
Yeah, we can't hear you, sir. Yeah, you have to unmute yourself. Yes. Yes.
Yeah. Now?
Yes, I can hear you.
Dr. Manke pointed out that we should take it up with RCA. As Dr. Nagaraj said, we do not know whether we are continuing as members of the subcommittee or not. Even if we are in subcommittee, our words may be noted, but no action will be taken. That is definite. And basically, see, the diplomas, we were talking about why can't we stop diploma? But as long as the politicians and the bureaucrats want it for their own purpose, it is not possible. I mean, they want to show that they're doing something for the people, and naturally that continues with that. They don't care whether they're meeting the ethics or not. And coming to ethics again, Dr. Nagaraj said we should prescribe do's and don'ts, or within the syllabus, these are the things for the assistants. I mean, I don't think it will work. Even, for example, our own people, they are saying that they should do the video stroboscopy. Are we trained or are we permitted? I mean, just this is an example I'm giving you. Like that, people, once they get out or once they get their degree, naturally they will start doing things that they like. So our do's and don'ts or ethics or unethical practices, they won't work, I believe. It depends upon the individuals rather than our prescriptions within the syllabus. That is what I feel. So we continue to put up with this. Maybe I sound very pessimistic, but that is the fact. Thank you.
Thank you. Yes, Suman.
As Kalani madam said, and I think there was a question regarding upgradation. Upgradation has not yielded any result, and I don't think upgrading them is a good option. Right now, we are having so many undergraduate programs that needs to be re-looked into whether one program is required or not. As the need was there, the program started. Now that program or the diploma program is taken as a base for getting graduates by different means. I don't want to spell it out, but the scope has to be defined, as madam said, that scope, if we define that these are the scopes, at least there will be some curtailment into the practice. Otherwise, if scope is not defined, even if we define the scope also, implementation is big issue, because everybody has got some or other interest into any program, because some has got their own interest, some has got their business interest, commercial interest, and that is the reason we are not able to achieve what we want to achieve. The question of association, any association is not attached with any government. So we have to only propose, we have to only request. Whether it will be accepted or not, that depends on the authority. And right now we have about just 21 odd diploma programs which are going on, and most of them are from the government side. I would say almost 50% of them. So we need to see how we can move forward, keeping the need. And also we have to see, we have already percolated at the level of district level and subdivision level in many places, with undergraduates and postgraduates working in different places. It is not the scenario which was there earlier 10-15 years back. This is what I want to put forth.
Okay, great. Seema Rupani, is there a diploma program or something of that sort back in Kenya? I guess she's not close to the computer. Let me go to the audience and take a look at the questions there. We have one suggestion from Meenakshi Vadera. Can we consider, let me read the question. Can we supervise these diploma holders virtually through Zoom or any other platform, so that we can eliminate the challenges of we not being in the rural area, but they could be there, and we could help them from distance mode? Any thoughts about that? Yes, Dr. Manke.
Yeah, virtual mode. See, this is a byproduct of COVID-19. 2018 and 19, we would have said no, 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 no to everything. And now, this virtual monitoring, virtual education, everything has become a happening thing. So I think we can move forward. It's a very good thing as such. It's only thing that diploma holder should sort of agree to be associated with me, because see, I have no interest in that business over there, but I can be a mentor. I can be a mentor. There may be so many people can be, but that mentor and mentee's agreement needs to be defined clearly, because if things go wrong, mentor will be held responsible. So then what are we going to do? But this something can be thought over, can be proposed by Isha, can develop the guidelines of how to be a mentor and how to sort of monitor these activities. Of course, there will be some legal issues, or the legal drafting will be required, because it's a remote monitoring of the activity, but worth exploring of it. It's a good suggestion. Thank you.
Great. Thanks, Meenakshi. To Seema Rupani, yes. Do we have any such diploma programs in Kenya?
Yeah, what makes it difficult, Nandu, is that we only have a diploma program in Kenya, and it's not very highly subscribed either. It's a handful of people who actually program every year. So no, we don't have any real successful training platform. And this is where I think, I can see the debate that India is having, but in my eyes, India is so far ahead from the rest of the world in any education in audiology. I think they've done tremendously well, and it's actually a very privileged position to now be at, where we're debating cadres and levels, because most of the other countries in the developing world don't really have as many education programs for audiology. In terms of the UK, what was interesting was the UK went through exactly the same dichotomy. They actually did something called a hearing aid dispenser licensing. So there was the audiology program, and then there was the hearing aid dispensing, and then there was the audiology assistant, and then there's the audiology physician. I think after a long time, all of these things are coming in terms of the hearing. Now, a minimum requirement is to do the BSc program for the hearing aid dispenser. What they have offered, who are actually practicing with audiologists, they've got the ability to do a foundation program and get a hearing aid dispenser, but you've got to be working with an audiologist and you have to have a minimum number of supervised hours logged before you get that. So yes, I think the whole world is transitioning through all these different roles in audiology.
Great, thank you. I think before we wind up, let me go back to the audience. There is one question, and it's from a non-audiologist, of course, from Mrs. Tavamani Radhakrishnan. She would like to know if wearing a cervical collar will impact hearing. Anyone with information on that? The cervical area being closer to the ears. Has anyone had any patients who had hearing problems because of cervical spondylosis or any of that disorder?
Recently, there was an article in some paper or something. It was in the WhatsApp media. I don't know how relevant it is and how much validated study it was, but there was something.
Okay, so that's great. I can recommend that article for them. So we are coming to wind this up. It was great 2 hours of discussion. I'm going to give you, each one of you, 1 minute to give your thoughts about DHLS and practice of selling hearing aids, which ideally should be by qualified graduates. So 1 minute to each one of you, and I'm going to start with who I see on my board here. Let's start with Mr. Manoharan. What are your thoughts in 1 minute about having DHLS program and make them prescribing hearing aids or selling hearing aids? How can we control that to make it more of a graduate student or graduate professional's role?
Yeah. See, as they were telling about this program has started to reach the unreached. Now, see, the problem, the need is there even in the Tier 1, Tier 2 cities. That's how the people are now here only in cities. They're not going to rural area. It's not their problem also. Actually, the government has to look into the various aspects, how we can reach out the village and taluk level. As they were telling about, they can have an expert committee in RCI. They can make certain amendments, how they can take it to the village. And also there should be some upgradation for DHLS people who are done a diploma course. If they want to upgrade their qualification, they should be able to join in degree course or anything that way. So that should also be there. And as Dr. Manke and there was a talk about virtual, I mean, this one, there can be made MOU with the DHLS candidates and the audiologists concerned that area. So they can have an MOU, but that has to be monitored once again by Isha, whether it is done properly or not. Regarding hearing aid prescription, the hearing aids are recommended by any doctor or even any family member, but prescription has to be done only by audiologist. The selling is different. So you can prescribe, you can select, give a trial, select proper hearing aid and prescribe this hearing aid with this much of gain and this much of frequency response, this much of output. It has to be given to the this here particular candidate. That kind of prescription can be done only by audiologist. At selling part, as hearing aid technician or anybody who is trained to sell hearing aid. Now there are so many entrepreneurs in our country. They have been doing it since quite a long time. but we have to regulate their practice of selling. There should be some system to regulate their way of practicing. That has to be once again done by RCA, how it has to be done.
Great, thank you. Dr. Nagaraja, your 1 minute starts now.
Well, I think I mostly agree with what Manoharan has said, but in the committees for redrafting the curriculum from diploma to post-graduation, practicing audiology should be included. It should not be left to only academicians. Academicians working as professors, assistant professors, etc., do not have the exposure to market, etc., kinds of things, and they will not be knowing how to do. That is one part. That is the committee, subcommittee developed by RCA. Or to develop that subcommittee, all the members of each audiologists, etc., has to pressurize by writing to them saying that the existing curriculum are different in this way, therefore it needs to be redrafted. There should be a time-bound schedule for them to do it. And the members should not be limited to only academic institutions of government. It should include NGO organizational representation, plus the practicing audiologists and SLP. That's my view. Thank you for coming.
Thank you. Dr. Nataraja. Yes. Your final words about DHLS and their future.
Yeah, there are a lot of things need to be done, of course, as they have pointed out. One thing that Mr. Manoharan pointed out, there is a scope. I mean, in the sense, the diploma holders can get into BSc with 1 year exemption. That has been provided by RCA. They can directly get into BSc. Of course, that is being used by some of the institutions and others are not using. But there is an opening for them. One, maybe as the discussion went on, we must find some way of carrying them with us. There is no other way, I believe. We cannot really, when you cannot get rid of something, so better you carry it with you in the direction in which you want, in the sense to improve this one. Just like they prescribe, or the RCA has prescribed that the members should get the upgradation or continuation of membership by undergoing training programs or taking some courses. I think maybe it is necessary to introduce the same kind of a thing for diploma holders also, and upgrade them also with the recent knowledge. That is the only possibility that I can think of. Thank you.
Thank you. Suman.
I feel that if a person needs to be treated at a different level, and considering the requirements earlier and now, I think there is a need to rethink on continuation of diploma program, because what we had earlier and what we have now is entirely different. And like in medical field, everybody has some basic degree, and for any specific reason they have to meet the specific people. So in similar way, if a person has got some kind of communication disorder or hearing impairment, they have to be treated by the same level of people, whether they are in mega city or they are in district level. This is what is my view.
Thank you. Siddhartha?
You know, I'm a big proponent that we should dispense hearing aid ourselves, because we can. The truth is there is no way to prescribe hearing aids, because the new technologies are such that you have to do it yourself. It is not like 1970 where audiologists used to not dispense hearing aid. They would write a prescription, and the person would go to a dispenser in US. And then in 1973, I think, the Academy of Dispensing Audiologists did a court case, and it went up till the District Circuit Court, and the audiologists were granted the permission to dispense hearing aids. I think it's a highly skilled job. It's not easy. I think it should be done. There was a time when there was a need. I think the need is fulfilled. There should be means to phase it off. What Dr. Nataraj has said, it is correct. We cannot disown them. If they are along with us, we can monitor them. We can, we can make sure, they're doing the right thing. But at this point of time, when there are so many good programs in India, and most of the programs in India have some standards, because of the kind of because part regulation, part because a lot of the mentors or the founders of the institutes come from the core institutes of India. I think I personally think there is they need to be phased off gradually. That's my take.
Great, thank you. Seema Rupani.
Right. I actually have a question at this stage. Is there actually a regulation on the sale of hearing aids in India? Where this question's coming from is, I think, regardless of where a patient obtains their hearing aids from, patients need to be aware that there is a minimum service requirement or minimum set of things that they should be expecting when they receive the hearing aid. I think this is what helped the UK progress on this side, that there was actually a patient who got a hearing aid had to get a 30-day trial, had to get the ability to return the hearing aid, had to get a certain number of tests, air, bone conduction, masking. And more importantly, they had somewhere to complain to, or in case they didn't get those services. And if they complained, there was quite a proceeding, and you could be struck off the register. So it probably is one of the ways in which we can create a regulation and more consumer awareness as to what they should be expecting when given a hearing aid, including the fact that they shouldn't actually just get a hearing aid and walk out. They should be provided an aftercare service as well. So I think eventually that kind of thing would help to bring the whole situation forward.
Thank you. Dr. Manke.
First, to answer the question about Seema, that there is no regulation for hearing aid because this is not a medical device right now. It's a consumer. It's registered under consumer. So all those rules are not there. We may work on it, but anyway, it's a long story. What I feel about is walking with all these people, means diploma holder, non-qualified people, even ENTs also, because who are doing a lot of dispensing of hearing aid and all. So it's our responsibility and probably sort of walking an extra mile, because that will help us for our own advocacy. We have failed to do our advocacy about our profession, about telling people who we are, what we do, and how we do, and how we are different than others. But if you make a handshake with these all people, this is possible. If you create you, me, they kind of thing, the walls, then the war will be on always. So I feel it just walk with them and keep on doing advocacy, subtly tell them how different you are from others. Even people will realize, and then tomorrow is ours. Thank you.
Thank you very much, team. It was great 2-3 hours discussing about a burning issue that's going on in India. And I call it burning because I picked all the, my panel were very subtle. There are people who can just pounce on each other when we talk about this particular topic. So I'm glad we had a good discussion. And what is going to happen with the program, the DHLS program, time will answer. Thank you very much, and signing off.